All right, guys, so today on Road to 250, I'm going to talk about the Lac Operon. The bug is going to be E. coli, and jog is going to be random, but Thiazides. So, okay. Alrighty, well, that's wrong. Okay, so the general idea of the Lac Operon is essentially it's a type of gene regulation. So it's just kind of a better way of testing it since it's better studied and understood. But the idea is the operon is required for transporting transcription and metabolism of lactose and E. coli, which is how it usually shows up on questions, and many other enteric bacteria to make ATP. So how does a cell know which substrate to use? Because the Lac Operon has available to it glucose and lactose. So in order for it to be energetically efficient, the cell is going to pretty much prefer to use glucose since it's readily available. But if there's no glucose, then it's going to use lactose if available. So with that said, it's important to keep in mind that if there's no glucose, if there's no glucose available, then the cell does need to expend its own energy to make these lactose metabolites. So the Lac Operon comes into play to sense or when there is, so the Lac Operon comes into play depending on what source is available, glucose or lactose. All right, so then looking at this chart here, if we have glucose and lactose available, maybe, okay, so if we have glucose and lactose available, what would the cell prefer to use?
Glucose?
Right, glucose, which is readily available. Even if lactose is present, glucose is going to be the preferred source because it doesn't have to expend any of its own energy to make the lactose metabolites. If you have a cell that has no lactose available, or sorry, no glucose available, but lactose available, will it need to make lactose metabolites?
Yes.
Yeah, exactly. So it doesn't have any glucose, so that's not an option. So it's going to have to use its energy to use the lactose and make lactose metabolites. If the cell has glucose available and no lactose available, will there be lac gene expression, aka will the cell be using lactose?
No.
Right, because it's not even available. So no lactose means it's not going to do any Lac Operon business, no lac gene expression. And lastly, if there's no glucose and no lactose, what do you think the cell is going to do? Will there be any lac gene expression at the least?
No.
Right, exactly. There's no lactose, so it can't use anything to even make lac metabolites. Now, okay, the title of this is wrong, but what I did want to kind of tell you guys in general is, actually, let me come back to this in a second. Oops. Oh, no. Okay, so a lot of things happened wrong. I chose the wrong animation type, but that sucks, but that's okay. So to start off with, here's a Lac Operon. This gray area you see here is going to represent the DNA. And then right upstream of the gray bar here on your right is going to be your lac genes. So lac Z, lac Y, and lac A. And these are the genes that are needed to metabolize lactose. And further upstream of these genes is where regulation occurs on whether or not we want to transcribe these genes into mRNA, and that would essentially lead to making proteins that correspond to these genes. So an important point that is, an important point to make note is that this is a prokaryotic cell system, and so prokaryotes make something called polycistronic RNA. Does anybody know what that is?
Okay. Mm-hmm.
So polycistronic RNA is essentially something that's unique to prokaryotes, and it has more than one gene on it. So it can do continuous rounds of transcriptions, and it will make a mRNA molecule that has the 3 genes needed, so the LAC-Z, LAC-Y, and LAC-A on it. And the difference is that this does not happen in eukaryotes, aka us. So in order to know what we need to transcribe these genes, we essentially need to go back to the idea of whether there's glucose or lactose present. If there is no glucose present and there's plenty of lactose, we are then going to proceed to transcribe the LAC genes. So okay, I'm just going to have to go backwards. Okay. Okay. So the first, okay, there was something else here too that got messed up, but that's okay. Okay, so the first enzyme that's needed in order to begin LAC genes transcription is going to be that ATP, adenylate cyclase, is going to convert ATP into CAMP. And once we have CAMP, this is going to stimulate or bind to this protein, which is CAP, or catabolite activating protein. And once this has bound, the entire complex will then bind to a CAP site that is on in the initiation location. And so it's going to bind to the cap site on the DNA. And that is, in turn, going to stimulate the promoter, and specifically RNA polymerase, in order for transcription initiation. Okay, so lost track. Make sure I didn't forget anything. Okay, so again, remember, we only want to transcribe if these genes have lactose available. So to ensure that we don't transcribe if there is no lactose available, there is a inhibitor protein, and that's encoded also in the DNA by LAC-I, I for inhibitor. And what the LAC-I codes for is a protein called the repressor protein that will bind to the operator here and prevent RNA polymerase, this red little structure, from transcribing the LAC genes. So that's going to happen. It's going to repress if no lactose is available. So just to make sure there's no glitches, this repressor protein here will prevent it from transcribing if there is no lactose. So if lactose is available, it's gonna if lactose is available, then here this allolactose is gonna bind to the repressor itself, preventing it from binding to the operator site. So if lactose is available, we are going to transcribe the LAC genes. Does that make sense so far? Mm-hmm. Okay. Now, if glucose is present, we don't want to transcribe the genes because, of course, we have glucose. So we don't need to spend all this energy doing any of this transcription. And now I don't have like a visual for this, but in addition, to make sure that if glucose is present and none of these processes take place, glucose will bind to a site on adenylate cyclase. And so that's going to prevent the cap protein from binding to the cap site or recruiting RNA polymerase. And none of that will happen. But these two processes are still not 100% proof of preventing things from happening. So especially in the case if you have both lactose and glucose present, and the eukaryote needs to kind of figure out like what they want to use. The LAC-I is not going to bind to the operator because, of course, there's lactose available. So, if you have both glucose and lactose available, the laci won't bind to the operator, and the cap won't be activated because it's like confused. So in that case, when you have both present, you're going to overall have a low level of transcription. Like some of it's going to work properly and some of it's not. And last thing is that if you have no lactose, you get no transcription because the inhibitor protein is pretty reliable. So this repressor protein is quite reliable. So in the case of no lactose, it's not going to use the energy to even go through activating, stimulating any of these things. So that's my Lac Operon for you guys. Any questions? Sorry, I wished my animations were right, so that would have been more visualistic, maybe.
It's okay.
Any questions or anything anybody wants to add that they've seen?
I'm good.
Good.
Alrighty. So, alright. Okay, so the bug of the day is E. coli. Okay, I did it right. Okay, so I guess I don't even have to ask really, but E. coli is a gram-negative bacilli, and it does lactose ferment. It is a lactose fermenter, and it is a fast lactose fermenter. Okay, well, so, all right, E. coli. So E. coli is encapsulated, and, before I start going over its characteristics, can you guys tell me what type or what color colonies lactose fermenters grow, aka E. coli would grow? I ask because it is a good clue to know in questions sometimes.
Green?
No, what'd you say?
Never mind, I take it back.
I don't know what you said, but it grows pink colonies on McConkey's agar. And does anybody else know what other bugs are also lactose fermenters, aka also grow pink colonies on McConkey's agar?
Club?
Yeah, Klebsiella, Serratia, and Enterobacter. So, moving on, E. coli is encapsulated, and it does have it does have a characteristic called the K capsule or K antigen, which presents on the capsule, and it's important for serotyping, which I'll mention why that comes into play in a little bit. In addition, if we grew E. coli on Eosine methylene blue or EMB agar, the colonies would be green or green sheen colonies. E. coli is also catalase positive, so important. And then it does have a virulence factor, which is the fimbriae. And the fimbriae or pili, so I believe from what I've read that fimbriae and pili are kind of interchangeable or represent the same idea in that it's important and necessary to cause UTIs for binding in the urinary tract. So, and that is important because 80% of UTIs are caused by E. coli. So the number one most common cause of E. coli in the general population, so not exclusive to males or females, is E. coli. In addition, E. coli also causes gram-negative sepsis. It is also a leading cause of gram-negative sepsis, especially in neonates, which I will mention in a little bit.
Go back.
Okay. Yeah. Okay. So to start off with, EIEC enteroinvasive E. coli is a microbe that invades the intestinal mucosa and causes necrosis and inflammation. So EIEC is invasive, it's dysentery, and its clinical manifestations are going to be similar to Shigella, which I'm going to describe in a second. ETEC, it is known as traveler's diarrhea, and it's specifically transmitted by water sources, and classically in vignettes, maybe they'll mention travel to Mexico or traveling out of country, hence traveler's diarrhea. And it does produce two toxins, the heat labile toxin, which increases CAMP. And does anybody know what that's similar to? What other bacteria increases CAMP? Or like has a pathogenesis?
Vibrio.
Yeah, exactly, Vibrio. And the other toxin that ETEC produces is the heat stabile toxin, which increases CGMP. And overall, ETEC is watery diarrhea, which is important and different from EHEC. So enteropathic pathogenic E. coli, there's no toxin, but it adheres to the apical surface, flattens the villi, and prevents absorption. So patients are going to get diarrhea, usually seen in children. Think EPEC pediatrics. All right. Now, EHEC, or enterohemorrhagic E. coli. Maybe one thing I want to, okay, I'll say it at the end actually. So EHEC. EHEC is commonly transmitted by undercooked meats, so hamburgers commonly, and it does cause bloody diarrhea. It does not ferment sorbitol, and the toxin that it creates is one that inhibits ribosomes of the 60S subunit, which is our Shiga-like toxin, and the Shiga-like toxin causes hemolytic uremic syndrome. So this patient is usually going to be a child, but doesn't withdraw from it being an adult, and it has a triad of anemia, thrombocytopenia, and acute renal failure due to microthrombi forming on damaged endothelium. So essentially what happens is the Shiga-like toxin is going to damage endothelial cells of the capillaries and the glomerulus, and the damage of the endothelium is going to cause thrombogenesis to occur, so causing platelet aggregation. And then these aggregates are going to lyse the RBCs, and so causes like hemorrhagic, or I guess that's the idea of mechanical hemolysis. So you'll see schistocytes, platelet consumption, and decreased renal blood flow as it's going to be clogging everything up. And then, okay, so the serotype here is associated with that K capsule or K antigen. It's associated with the O157H7, most common serotype in US. And it is essentially the serotype that's going to cause a massive outbreak. So that's what I know it as its association to. Okay, and then the last thing I was going to mention is the LPS endotoxin, which causes septic shock. So the lipopolysaccharide endotoxin is located in the outer cell membrane, it being gram-negative, and it causes meningitis in neonates, only when positive for that K capsule. And as you remember, what other bugs are most commonly affecting neonates? Causing meningitis?
Neisseria.
Not neonates. So specifically 0 to 6 months would be the neonatal period.
Haemophilus?
I remember this as baby gel or baby bell. So group B strep, E. coli, and listeria. And that's going to be 0, so neonates specifically 0 to 6. Neisseria and Haemophilus come into play like from 6 months to like, I don't know, maybe 18 years old, I think was the next group. But yeah, so that's what I have for E. coli. Any questions? Anything anybody want to add? All right, then moving on. Oh gosh. To the bug of the day. Okay, so thiazides is the bug of the day, and thiazides are going to be most commonly, predominantly causing an effect at the DCT. I think I was supposed to ask you that, but clearly that didn't work out. So moving on, thiazides. So these are going to be our drugs: hydrochlorothiazide, chlorothiazide, benzoylflumethiazide, chlorothiazidone, and metalazone, and indapamide. So these are all sulfonamide derivatives, and their half-life is 6 to 12 hours. And the mechanism of action. So thiazides are secreted by the proximal convoluted tubule, but exert their effects on the DCT. So as a drug itself, it's going to be secreted by the PCT, but its effects occur on the DCT. They inhibit the sodium chloride symporter from the lumen to tubular cell. So it increases sodium and chloride excretion and water that goes along with it. And also, which I did not know, some thiazides actually have a weak carbonic anhydrase effect, but it's weak, so it's not going to be primary. And there we go. That's where your symporter is, sodium chloride. Okay, so the general idea or effects of thiazides on electrolytes is that it's going to increase sodium and chloride excretion. It inhibits uric acid secretion, hence why an adverse effect is going to be hyperuricemia and gout. It decreases calcium excretion and tends to increase the plasma calcium, therefore, and hence delays osteoporotic processes. It also increases magnesium excretion. Okay, so, so a good mnemonic that the first aid has is hyperfluke, which is going to be the G for glycemia, L for hyperlipidemia, U for hyperuricemia, and C for hypercalcemia. Okay, so to talk about the adverse effects, the fact that thiazides cause hypokalemia leads to an increased risk of patients who are using or on digitalis to cause digitalis toxicity. So the reason why in the first aid it says digitalis toxicity is caused by hyperkalemia, why an adverse effect of digitalis is hypokalemia is actually because the patient is in a state of already being hypokalemic, and then digitalis on top causes further hypokalemia, and that's why toxicity occurs. It also causes hyponatremia and hypomagnesemia. Hyperuricemia is going to be a cause for caution in gout arthritis. Hyperglycemia and hypercholesteremia are not going to be favorable for diabetic patients and those who have dyslipidemia. And so thiazides decrease insulin secretion and glucose uptake by the tissues, leading to impaired carbohydrate tolerance and hyperglycemia. So actually, I'm going to talk about that a little bit in detail in a second. Some last bits on adverse effects are that indapamide has less effects on lipid and uric acid, so maybe a more favorable drug to use. Hypercalcemia is actually, when used in long term, it's good for the elderly to prevent that osteoporosis process. Increased renal tubular calcium reabsorption will actually suppress the PTH, which can actually cause hypocalcemia to occur afterwards. So that's something to keep in mind. And the last, sexual dysfunction can also occur. I don't think it's very common, though. Indications are what we would use thiazides for. So hypertension, either single drug or in combination. Chronic or mild heart failure. Edema, however, loop diuretics are going to be the most quickest and favorable. Nephrogenic diabetes insipidus is going to be one we want to use thiazides for. And then prevention of calcium excretion in osteoporosis and calcium nephrolithiasis, so kidney stones. This is a good drug to use for kidney stone prevention. Okay, so why are thiazides detrimental to patients who are diabetic? Okay, so the idea is that thiazides are causing both sodium and chloride, pushing them out of the collecting duct. And so the rebound effect is there's too much aldosterone that is secreted in result of making up for what's being lost. And so potassium, with that whole aldosterone system process going on, is causing potassium to be excreted into the urine. And we already know that thiazides cause hypokalemia. So now that we have very minimal potassium, it's going to affect the beta cells. And we know that because it's potassium helps release of insulin. So when we have not enough potassium, it's going to cause hyperglycemia in this patient. So we avoid it in diabetics. And specifically, potassium is stimulated or is used in the stimulation for insulin to be released. So when we have increased glucose levels, we need insulin to push the glucose into the cell. So beta cell closes up a ATP-sensitive potassium channel, which is used to depolarize the beta cell. And when depolarization occurs, it causes rapid influx of calcium via the voltage-gated calcium channel. And this is going to stimulate the secretion of insulin by activating insulin gene expression via CREB, which is a calcium-responsive element binding protein. So the idea is that's the normal. So if potassium levels fall, depolarization cannot occur, and there will be no release of insulin. Blood sugars are then going to increase blood glucose, hence why thiazides induce hyperglycemia. Does that make sense? Mm-hmm. And here's a picture. So here's the ATP potassium sensitive channel. And this is where the potassium needs to come in order to cause influx of calcium, in order to cause release of, so depolarization and then release of insulin. So that's the normal, and then this would be the abnormal. No, we can't, if there's no potassium influx, there's no calcium influx, and then no release of insulin. Sorry, the picture quality is bad, but. Okay, and then to allude from that idea, the hyperlipidemia is kind of connected in the sense that insulin blocks the enzyme hormone-sensitive lipase, which is normally releases triglycerides into the system. So thiazides are going to decrease insulin release from the beta cells, which result in release of stored triglycerides. So hormone-sensitive lipase is in overdrive. And so patients who already have hyperlipidemia are going to actually end up developing even higher levels of lipids in the blood. So that's what I got for you guys. Any questions, concerns, anything anybody want to add?
I think on the last slide you said where the potassium comes in, potassium gets shut down. It closes that channel to depolarize that cell, which then allows the calcium to.
Yes.
So just wanted to clear that.
Yep. Yes. Right, because of the GLUT receptor. So yes. Anything else that I might have babbled wrong?
Actually, that's also the site where sulfonylureas will act as well.
Yep, exactly. Good. Very good. Okay, so I have questions for you guys. Okay, so here's the first one. E. coli is able to grow on a medium containing lactose alone. No glucose or other sugars are present in the growth medium. In these situations, the bacteria must rely solely on lactose for energy. A special gene pathway called the Lac Operon allows E. coli to accomplish this task. Which of the following occurs in E. coli? Which of the following occurs when E. coli is plated on medium containing only lactose? A, allolactose binds a repressor. B, the levels of CAMP are decreased and the repressor is inactive. C, the levels of CAMP are increased and the repressor is active. I might have said that other one wrong. D, the repressor displaces CAMP repressor protein from the DNA. And E, the repressor is detached from RNA polymerase.
A.
A as well.
Yeah, you guys are right. That is, A is right. So when lactose is present, it's going to bind to the repressor, prevent or allowing for lac gene transcription to occur. Did you guys want to go over the other answer choices, or like confused about it, or?
Levels of CAMP would increase, but the repressor would stay inactive. So B and C are wrong.
Exactly. Yep. Right.
And the repressor displaces CAMP receptor protein. That doesn't make any sense.
Yeah. The CAMP is the cap protein, so it has nothing to do with the repressor. The repressor is only associated with binding to lactose and lac-I, or the lac-I gene and all that. And then even the RNA polymerase, that's the cap binding site again, so not repressor associated. Sorry, I think I stopped someone from speaking.
No, okay.
Okay, so next one. While working in a microbiology laboratory, a researcher comes across a unlabeled cryotube in the freezer. She deduces that it contains a strain of E. coli and decides to test whether this strain has an intact lactose operon. After growing the cells in a media containing both glucose and lactose, she observes that a considerable amount of lactosidase encoded by the Lac Operon is expressed compared with controls. Lactosidase production is also observed in the presence of lactose only. No protein products are produced when the E. coli is grown only with glucose. Based on this observation, where is the mutation most likely located? A, the catabolite activator protein. B, inducer binding site. C, promoter. D, RNA polymerase. And E, repressor. So we know that there's a lot of galactosidase produced, and we know that that's only going to occur if there's lactose present. But when it was only with glucose, it didn't even produce there was no protein products produced in the scenario that there was only glucose available.
A?
I would say too.
Yeah, that's right. A is right. Because, so the fact that no protein products were produced when E. coli was grown with the glucose is telling us that essentially when there was glucose present, it's supposed to be glucose is supposed to bind to the catabolite activating, it's supposed to bind to adenylate cyclase to prevent anything else from occurring. But that's not occurring, and none of those things, like inducer binding site, can't occur if there's no lactose and there's no glucose available. And their inducer site is just not going to be associated. Promoter, RNA polymerase kind of go hand in hand. If the catabolite activator protein was binding to the site, and then the repressor is only going to be if lactose is available. That's its only association. So,
just to add to that a little bit, so if you have high amounts of glucose, you're not going to express the Lac Operon. So what's happening when it's only with glucose is normal, but when she has both, when she's growing it in a medium that has both glucose and lactose, you're getting an enzyme that's supposed to be coated by the Lac Operon, which means that glucose isn't stopping the CAP site from doing whatever it wants.
Yeah, exactly. Yep. Very good. Okay, last question. A 72-year-old man is brought to the emergency department from a skilled nursing facility due to altered mental status, skin flushing, and a high fever. As temperature is 102, blood pressure is 80/40, pulse is 120 per minute, and respirations are 26 per minute. If blood cultures are positive for E. coli, which of the following is the most likely site of infection leading to bacteremia in this patient? A, biliary tree, B, colon, C, lung, D, oropharynx, E, skin, F, small intestine, G, urinary tract.
G.
We have a G. And Divya?
Sure.
So the answer is G, and the idea is E. coli, number one most common cause, is going to be, of UTIs, is going to be E. coli, but the patient has bacteremia, and you can associate the fact that they had a UTI leading to bacteremia. And he has like a high fever, so that could be like another indication, I guess, like of bacteria, but yeah, because, biliary tree, lungs, oropharynx, skin, and small intestine are probably not going to be any of your differentials, as the only other thing you can think of in terms of bacteremia association is clearly not meningitis, since it's not neonate, and then the hemolytic uremic syndrome, but that's like kidney, and it's going to be associated with like the thrombo. I can't think of the words all of a sudden, but the schistocytes and breakdown of RBCs and all that.
Yeah. Also, because E. coli has the whole pili binding advantage, so it's probably going to be in the urinary tract where it can hold on.
Exactly,
to
it's
those
virulence
membranes.
factor, fimbriae/pili. Yep. Okay. One quick thing I thought about that I forgot to mention, since we ran over that one question, was this slide. So I don't think it's so high yield, but just to go over it, I found this information last minute about what exactly LAC-Z, LAC-Y, and LAC-A encode for. So LAC-Z is actually, it encodes for beta-galactosidase, which then serves the purpose of cleaving lactose, which is a disaccharide, into glucose and galactose. LAC-Y encodes for beta-galactoside permease, which is going to be important in cytoplasmic membrane. So it's embedded. So this protein is embedded in the cytoplasmic membrane, which enables transport of lactose into the cell. And then LAC-A encodes for beta-galactoside transacetylase. So I think it's maybe just good to know. But that's it.
Awesome.